Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Thank you for downloading and listening to This Pathological Life. If you're interested in continuing the story, we have a second series called This Medical Life. Please download it and subscribe now.
Dr. Travis Brown, why do we need a podcast called This Pathological Life?
Every disease has its own story to tell. So we're going to tell them.
In this episode of This Pathological Life, we're looking at something, Travis, that I've heard a lot about, but I've never delved into. Hodgkin's lymphoma.
Yep.
What's made you choose this?
Look, you realise when you're looking at all the diseases through a textbook that names stick out. Mm-hmm. And so then you see that, well, Hodgkin's lymphoma. And it's not until, well, why is it called Hodgkin's? Now, you actually find a whole bunch of names, and then you realize it's actually because someone is either named after it, and Hodgkin's lymphoma is a distinctive disease, and one that affects a lot of adolescents and young adults. And so it's quite prominent because you sit there and go, oh my goodness, this person has cancer. And so then I wanted to look, well, who is, what is Hodgkin's lymphoma? Who discovered it? And clearly it was a person by the name of Thomas Hodgkins. Mm-hmm. And he was born in 1798 and described as a precocious child and a young man who had interest in, geology and mathematics and chemistry. Found himself in medicine and then worked his way at that time to pathology and anatomy. During his studies, he was in London and England at the time of those studies, made his way across to Paris during these studies and started bumping or rubbing elbows with influential people in medicine. And it had an impact on his future. And what he learnt there was to prepare and dissect cadavers and, get specimen preparation in Paris. And so, in 1825, after a year in Paris, he returns to London. So there was a political struggle between some hospitals. One was St. Thomas and the other one was Guy's Hospital. They were part of the same group, but there was clearly differences of opinion, and they ended up deciding to split. But the problem with that is because people have medical students, they need teaching materials. Well, St. Thomas had a anatomy library that had brains and hearts and stomachs and skeletons to aim to design to teach their medical students. Well, Guy Hospital didn't have any of these. And so there was a problem because then St. Thomas got all the anatomy specimens and Guy Hospital didn't get any. But here comes Thomas Hodgkin from Paris, newly, crowned, with exposure in developing autopsies and anatomical specimens. And so it worked out well. So Guy Hospital employed, Thomas Hodgkin in 1825, and then must have been very good at his job because in 1826 they made him the Inspector of the Dead, another title as well as Curator of the Museum of Morbid Anatomy.
Wow.
And over the next 3 years, he got over 1,600 specimens to be displayed. He described conditions such as the perforated appendix and peritonitis. He noted the lymphatic spread of cancer and noted the similarity between a tumour and its spread in a lymph node, so was able to see that there was a similar appearance. He even described what was called then a retroversion of the valves of the aorta, what we would call today aortic regurgitation or insufficiency. Now, the person who's credited with that is a person by the name of Dr. Dominic Corrigan, who did it in 1833, which is about 7 or 8 years after he's written these information. So he was clearly a remarkable person. and he was also conducting autopsies. So in 1832, he presented a paper, and it was called On Some Morbid Appearances of the Absorbent, Glands and Spleen. Now, absorbent is what we would term now lymphatic. And he got 6 patients with their clinical history who died from this disease, and a case from a friend who he called Carswell.
The morbid alterations of structure which I'm about to describe are probably familiar to many practical morbid anatomists, since they can scarcely have failed to have fallen under their observation in the course of cadaveric inspection.
And he was right. Others had noted enlarged lymph nodes before in specimens. So any infection will increase it. Other malignant changes will increase it. So it's not unique. The difference is that Thomas Hodgkin was the first to hypothesize that this was a primary disease of lymph nodes, so it was coming within it itself. Now, the article didn't become widely known, and even Thomas was understated about the contribution of this paper.
A pathological paper may perhaps be thought of little value if unaccompanied by suggestions designed to assist in the treatment, either curative or palliative.
So he didn't. It was just a descriptive paper on 6-7 patients who had this pathology. And this was in 1832. And it wasn't until 1865 when a Dr. Wilkes wrote a paper on a similar condition. Now, he called this Lardaceous disease. And when he published it, he then became aware of Thomas Hodgkin's paper and then renamed his paper Cases of Enlargement of the Lymphatic Glands and Spleen, or Hodgkin's disease with remarks, which is quite remarkable when you think about it. And unfortunately, 1 year later, in 1866, that's when Thomas Hodgkin died. But it was around this time that histology was increasing. So we note that Thomas Hodgkin was doing this all macroscopically. In 1870, we have Tuckwell, who describes an autopsy of a 49-year-old female who had enlarged lymph nodes. And in these lymph nodes, when they looked at them, there were large cells containing these 2 or 3 nuclei. And then we have a drawing in 1878 from Greenfield of these cells. And then it's in 1898 we get Carl Sternberg, and in 1902 Dorothy Reed, who arrived at a conclusion.
We believe then, from the descriptions in the literature and the findings in 8 cases examined, that Hodgkin's disease has a peculiar and typical histological picture and could thus rightly be considered a histopathological disease entity.
So we get our first definitive description of these cells. These are large, giant cells that are cleaved or bilobed nuclei. And the description is given of owl eyes glaring sullenly out of the forest of lymph.
Wow.
So these 2 people, Carl Sternberg, so he believed that this was a form of tuberculosis, and that's because 18 of the 13 patients that he had studied had TB. Dorothy Reed, however, she emphasized that Hodgkin's was unrelated to TB and used animal inoculation to prove it. So it's important to note that one of the aspects of Hodgkin's lymphoma is its propensity to spread locally. So it will start in a lymph node and then spread to surrounding lymph nodes. And today we even use this in a staging. So you have one lymph node area affected, it's a stage 1. If you get 2 lymph node areas separate, stage 2. Above and below the diaphragm at stage 3, and if it involves organ, it's stage 4. Now, in 1947, we get a classification of this Hodgkin's lymphoma by Jackson and Parker. And so, they put it as Hodgkin's granuloma, the so-called typical cases. There was a different variant of Hodgkin's sarcoma, which had pleomorphic cells and anaplastic Reed-Sternberg cells, as they were called now, because they did the description. And then we have Hodgkin's granuloma, which was a slow progression and had lots of lymphocytes, but really Reed-Sternberg cells were really hard to find. And then 20 years later, we had another group that added heterogeneous granuloma, which we would now know today as nodular sclerosing. And it wasn't until the 1960s that we found the cytogenetics of these Reed-Sternberg cells, and they confirmed that they were the neoplastic ones. With our classification system now, we have 5 variants: nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte-depleted, and lymphocyte-predominant. Now, I'll just take us back just one moment to 1926, when a Dr. Fox was able to examine the original cases that was described by Thomas Hodgkin. Now, he had 6 cases, plus the 1, but the 6 cases were examined. Now, because he was, Thomas Hodgkin was an anatomist and preserved things, they had preserved these 6 cases. And of those 6 cases, 3 had classic Reed-Sternberg cells, so were Hodgkin's lymphoma. But 1 was a non-Hodgkin's lymphoma, 1 was TB, and 1 was due to syphilis. This just highlights even the initial classification that lymph nodes are hard and lymphomas are hard. And so we're going to bring in an expert to help us sort out some of this information, because we need help in this area, and to try and work out how do we diagnose this best.
And this expert has been on this podcast before.
There was a small lump just above my collarbone where that scar is, and I was getting everyone to feel it and poke it, which I probably shouldn't have. But I was like, I didn't know what it was. It was the size of a pea to begin with. They had to put a needle in and sort of poke it around to try and get some of the liquid that was inside it to test it. It was so painful. Like, I hate needles, but even in my arm, never mind having it in my neck. So I hated that. And then when the test results came back, then she said that it was Hodgkin's. And then she said it was a type of lymph cancer. And I don't know, I can't really remember how I reacted.
Let's continue with this pathological life now, and we're welcoming back to the podcast for his second visit, Dr. Brad Webster. Welcome back, Brad.
Thanks for having me.
I should mention, of course, you're a histopathologist with a special interest in lymphoma. So let's start with the definition of terms. How do you define lymphoma?
So a lymphoma is a malignant tumour of lymphocytes, and lymphocytes are the cells that are responsible for adaptive immunity. So adaptive immunity is an antigen-specific immune response. So it's something that requires prior exposure to a pathogen, and then it develops memory. So the next time you encounter that pathogen, your immune response is quicker and stronger. So that's essentially what we're trying to do when we vaccinate. We're trying to trigger this memory so that when your body is exposed to the pathogen again, it can, produce this protective immune response. So lymphocytes are divided into 2 groups, broadly speaking. You have your B cells, which are responsible for antibody production, and you've got your T cells, which are responsible for cell-mediated immunity. So in particular, the T cells are important for viral immunity and tumor immunity. So lymphocytes traffic around the body. So you've probably heard of a lymph node. So lymphocytes will move between lymph nodes and also through lymph. And lymph is the fluid in the intercellular spaces in your tissues. So that flows back through a lymphatic system and will flow through numerous lymph nodes and then ultimately back into the bloodstream. And it's in the lymph nodes that the lymphocytes are exposed to foreign antigens. So essentially the lymph node is built so that the lymphocytes can be exposed to foreign antigen and can then hopefully find the antigen for which the lymphocyte is specific.
Right.
And then that leads to the immune response. So when I say that lymphocytes are waiting for the antigen for which they're specific, so B cells and T cells have a very, very specific receptor. So in B cells, it's a immunoglobulin or an antibody. In T cells, it's a T cell receptor. and they're able to develop this amazing specificity by when these cells are first differentiating. There's essentially a process of controlled mutation. So there's DNA breaks and induced mutation that hopefully develops a very unique and specific receptor. And when that specific T or B cell finds its antigen, then it starts to proliferate and differentiate, and then that's what produces the immune response.
So when we're looking then at lymphoma, so this is a malignant transformation. So is it part of... It's hard to say. We have two classifications of lymphoma, effectively a non-Hodgkin's lymphoma and a Hodgkin's lymphoma. Now, how do we classify? Because effectively we've got a diagnosis and everything else fits into the other category. Is that right?
Yeah, so lymphoma, broadly speaking, is divided into non-Hodgkin's or Hodgkin's lymphoma. So the majority are non-Hodgkin's lymphoma. But within that group, there is an array of different entities or classifications. So the WHO have a classification system, and the aim is to try and to pull out these well-defined entities that have particular sort of diagnostic criteria and that have value from a prognostic and therapeutic point of view. So there's a range of things that go into making that classification. So in the past, it was based on cell morphology. So is it a small cell? Is it intermediate? Is it large? And then we had some new technologies, so we could phenotype. We could look at what's on the cell surface. So we can classify it by, is it of B cell origin or is it of T cell origin? And there's another cell type called NK cells, but we won't go into that. So some lymphomas have specific surface markers that we can look at. Then we have genetic changes. So some lymphomas have very specific genetic translocations. And then, of course, there are the clinical features. So all those are brought together to create a specific lymphoma entity. Now, if we go on to Hodgkin's lymphoma can be divided into classic and non-classical subtypes. So the classic subtype is about 90% of Hodgkin's lymphoma, and there are 4 different histological patterns. And that's really only important for the pathologist. There are some differences in clinical presentation in terms of, the age of the patient or the favored site of involvement. But essentially, once staging has occurred, so staging is we look at which nodal groups are involved, there's not really any difference as far as treatment or prognosis.
Right, okay. So then when we look at... The challenge is there's many causes for lymphadenopathy, so for big lymph nodes then. Clearly, they're not all lymphoma, and we all know that, neck glands get swollen when, you've got a sore throat, something to that effect. Do we have many causes? What's the common causes for lymphadenopathy that you would talk to a GP about? Yeah,
so, when you think about the role of a lymph node, it's essentially to elicit an immune response. So lymphadenopathy will occur. So lymphadenopathy is an enlargement of the lymph node. And so that can occur in a reactive context. So that might be there's adjacent infection or inflammation. Maybe you've got a spider bite, and in the lymph node that drains that site, that will become enlarged. It might be a little bit tender. I think everyone can relate to that, where you've got some enlarged glands in your neck. But there are other causes of lymphadenopathy, and the ones that we worry about are neoplastic, so tumor causes. So one cause, neoplastic cause, would be a metastasis from a carcinoma or a melanoma. And then, of course, given we're talking about lymphoma, a lymphoma can cause lymphadenopathy because these malignant lymphocytes have receptors that traffic them around to the lymph nodes. Although lymphomas tend to be in lymph nodes, they can occur in extranodal sites. They can occur in the spleen, they can occur in the liver, and then each tissue seems to have some sort of lymphoid tissue associated with it. So the gastrointestinal tract can develop lymphoma, the lung can develop lymphoma. Pretty much any site in the body can, in theory, have a lymphoma.
So with investigations, main investigations with lymph nodes. So we have an FNA, so we stick a needle in, pull some cells out. We have flow cytometry, so we pull some cells out and we run it through a machine and tag it. You have a core biopsy and we have an excisional biopsy. Is there a preference for it from a histological perspective? What is the best bang for your buck with regards to a GP or radiologist when we're doing investigations for lymphadenopathy?
Yeah, so there's different sort of modalities that you can use, like you described. An FNA is a fine needle aspirate, so that's the least invasive process. It's relatively simple, quick to do, but it does have limitations. So when you think about what you're doing with an FNA, you're putting a needle in and you're drawing some cells out and then smearing them on a slide. So any architecture that you had within that node, it's basically these cells have been put in a blender and just spread out. So that architecture's gone. We're just looking at the cell morphology. So it's good if you think there's a possibility that that node is enlarged because of a metastatic carcinoma or a melanoma, because they, in general, look quite different to a lymphoma. Even a high-grade lymphoma, you'll at least be able to tell that you're dealing with a malignant process. When we're talking on the sort of more indolent or low-grade spectrum of lymphomas, it's more difficult because these low-grade lymphomas are usually composed of small lymphocytes, which are basically what the lymph node is normally composed of. And because we've lost that architecture, it can be difficult to tell if we're dealing with a reactive node or a low-grade lymphoma. So it is less sensitive in that respect. The good thing with FNA, though, is that you can use the material that you get and send it for flow cytometry. So flow cytometry, like you said, is looking at the cell surface markers on each individual cell. But of course, there are limitations there. So there's the sampling limitation, but we're only looking at a portion of the node. And there are some circumstances where you can detect a monoclonal population of lymphocytes. So when we say monoclonal, we mean that it's derived from the single cell type. So when we think monoclonal, we usually think neoplastic. But in some circumstances, you can detect a monoclonal population and it doesn't necessarily equate to lymphoma. And that's why we need the histological, or at least the cytological correlation. I'll just add, since we're talking about Hodgkin's lymphoma, it's probably good if I go back to talk about the difference between a Hodgkin's and a non-Hodgkin's lymphoma. Mm-hmm. So in a non-Hodgkin's lymphoma, the majority of the cells that we see are neoplastic, whereas in a Hodgkin's lymphoma, the actual neoplastic cell is a very small proportion of the overall mass of the tumor. So it could be as little as 1 in 1,000 to 1 in 100 of the cell population are neoplastic. Now, if you are looking for that on flow cytometry, you're probably not going to be able to pick that up. And same with an FNA, you're looking for maybe just a handful of cells out of hundreds or thousands. So for that reason, Hodgkin's lymphoma is better assessed on a histological specimen, and that could be a core biopsy or an excision biopsy.
Will it still be pretty hard to get on a core biopsy? So you would sit there?
Yeah, it can be. So sometimes you're lucky and you can see the neoplastic cells, so they're Reed-Sternberg cells or Hodgkin cells. Sometimes you just don't have enough on the core biopsy. So the core biopsies are very, still small pieces of tissue, might only be 1 millimeter or 2 thick. Depending upon what you sample, you could miss the diagnostic areas. Yeah. So if it's suspicious but not absolutely diagnostic, then we'd suggest an excision biopsy of that lymph node.
Yeah. Yeah, I'm trying to work out because the malignant cells are so small pretty much in a sea of lymph. The pathology behind it, is it because it causes such an inflammatory response that causes that they get so large, or is it again? I'm not quite sure how it fits in.
Yeah, so I mean, maybe if I can go back and talk about why we actually separate out Hodgkin's lymphoma from non-Hodgkin's lymphoma, and there's a few reasons. There's the historical reasons that it tends to affect younger people, although there is a second peak in the elderly. It has particular sites of involvement, so it lacks the cervical nodes. It's primarily a nodal-based disease, so extranodal disease is pretty uncommon. It lacks the cervical nodes, and it can involve the mediastinal and para-aortic nodes, for example. It has a sort of quite a typical pattern of spread, so it tends to spread to contiguous node groups. And the main difference is in the actual biology of the neoplastic cell. So we talked before about non-Hodgkin's lymphomas being B cell and T cell. There are other cell types that we won't go into, but the neoplastic cell in a Hodgkin's lymphoma doesn't fall neatly into that category. It's first of all, they're very rare. They're large. They're multi-lobated, so they look very different to a normal B cell. But people have done studies into this where they've been able to actually dissect out individual cells, and they've found that it actually is of B cell origin, but it's what's called has a crippled B cell gene expression profile. So it's a B cell that has lost the capacity to behave like a B cell, although it does express some of the markers that a B cell would. So a B cell typically expresses CD20. That's a B cell marker. And in Hodgkin's lymphoma, it loses that, although other B cell markers can be positive. So to answer your question about why are there so many other cells in there, the theory is that these neoplastic cells are producing substances, whether they're cytokines, that are attracting in all these reactive cells. So when you actually look at the lymph node of a Hodgkin's lymphoma, most of it is reactive. So there's lymphocytes, there's histiocytes, there's eosinophils, and scattered in amongst there are going to be a few of these Hodgkin-Reed-Sternberg cells.
Is there any advice that you can provide to GPs about how you would best manage, like if someone's coming in, you've got lymph nodes, everything, how far is Hodgkin's on the list, do you think?
Yeah, so I think it depends on the characteristics of the lymphadenopathy. So, people throughout their life are going to have enlarged lymph nodes if they've got an infection or a bite. They've had surgery. The wound healing might cause the draining nodes to be a bit larger. But the worrying features are if you have a large node, and then what is a large node? When you start talking about above 1 or 2 centimeters, it's sort of getting into what I would think would be a large node. If there's lymphadenopathy that's either persistent or progressive, that's concerning. If there's lymphadenopathy in multiple sites, or if there's the absence of some sort of initiating factor for the lymphadenopathy. The age is obviously important. So older people, if they have a history of malignancy elsewhere, you might be thinking it could be a metastasis of a carcinoma. If there are B symptoms, so we didn't touch on that, but lymphomas can have associated B symptoms, and these are the things like weight loss, night sweats, and fever. So when you start to see those, you might think that you're dealing with a lymphoma. When you have young people and they've got cervical lymphadenopathy, I think you need to have Hodgkin's lymphoma in mind. And often we will get FNAs initially as kind of to assess the lymph nodes in a young person. And as I said before, the sensitivity isn't that high for an FNA of a lymph node. So once you get a result back for that FNA, you kind of need to keep going, I think, if the lymphadenopathy isn't explained. So the next step would be to consider a histological specimen. So you might start with a core biopsy, or you could go straight to an excision biopsy depending upon the context.
Just before everybody leaves, I just want to throw one question without notice at you both, and it may be beyond your areas of expertise. I hear a lot of people in allied health massage therapists talking about having a lymph massage. That seems quite topical and superficial to me compared to the depth you've just taken it. Is that one of those things that should go with the liver cleansing diet, and it's all just a nice way to spin some extra bucks?
I'm just going to say no comment to that.
Okay. Travis, do you have more courage?
We both know I don't. If you want an answer, there's a lot of fads that come out. And so there's what is liver detoxification? Well, are you actually detoxifying? Well, that's the job of the liver. So you're always detoxifying it. If you're not having something that you're doing, probably the best thing you could not do is drink alcohol for a while, because that will stop the fatty liver. Is there a lymph massage? Well, as soon as you move your body, lymph is going into, the fluids going into lymph. So are you moving along? You're moving it along with everything, veins, blood's moving, everything.
Going for a run's probably
yeah. Exactly. You sit there and go, you see, the people doing ice baths. So yes, it will be a fad thing. It will be, the next thing that come up. But as I say, your body is pretty good at managing most things. I don't know what a lymph massage is actually meant to do, but just moving about will actually do the same thing. If someone squeezes your muscle, you're going to get lymph happening type thing. That's why...
Okay. I just think that having a massage is probably sometimes nicer than moving about.
Well, that's a completely different thing, but you're not doing it for your lymph.
Thank you again, Dr. Brad Webster.
Thank you.
I think because I took quick steps and got checked out, and then thankfully my doctor recognised that it probably was cancer, so I got rapid treatment. I had a really good prognosis and really good outcome. So I would definitely recommend that if anybody's concerned about lumps, or if they've got any questions about a change in their body, then they do get that checked out. I got some great advice to say, listen to your body. And I did do that. So I was told, if you feel tired, well, have a sleep. Or if you feel, if you don't feel like doing something, don't do it. And that was quite eye-opening for me, because normally if I feel tired, I'd think, you've got to battle on, you've got to keep going. But it was actually just listen to your body, do that, and my body responded really well.
All right, in the final part of this episode, Travis, how do we treat this? And once we tackle that, let's go and just refresh ourselves on the cause.
Okay. The treatment even has its own historical story. This starts with Henry Kaplan in 1950s, who was a professor of radiology at Stanford. He was interested in the use of X-rays to penetrate solid tumours, so things like lung tumour or breast cancer or lymphoma. What he ended up doing in 1953 was convincing a whole bunch of physicists and engineers to design for him an accelerator so that he could try and treat these things. And this ended up being installed in 1956. And what he ended up doing as well was he, from his neighbour, grabbed a huge block of lead shielding and put a pinhole through it so that he could then direct this huge radiation dose to where he wanted. Mm-hmm. And so he then wanted to manage these lymphomas and see, can I manage it by treating it with radiation and kill the cells? There'd been experiments in the past. A Swiss radiologist, René Gilbert, had tried to treat Hodgkin's lymphoma with radiation. The problem was the patients often relapsed in adjacent areas of the field of radiation. So you would treat an area and that would be fine, but then adjacent areas would get Hodgkin's lymphoma as well. So it was considered unsuccessful. A Canadian surgeon, Vera Peters, at Toronto General Hospital, started testing extended field radiation, so going for a large area of lymph nodes. Mm-hmm. Now, this appeared to be successful, but the problem is the data was retrospective. So looking back, it didn't have as much credence as saying, well, how do I test two different areas simultaneously and see if I get a better result? Right. Kaplan set out to prove this. And can Hodgkin's lymphoma be cured by radiation? Is it manageable? And so he set out two very separate patient groups. One, he did extended field radiation, and the other one, he did targeted limited therapy. He did meticulous stratification of patient cohort to make sure that they were in the appropriate category. And so even to the point of patients having laparoscopy and biopsies to make sure that they were in the right category to confirm Hodgkin's was only where they thought it was. And what ended up happening was he was able to prove that localized therapy to localized disease could be treated effectively by radiation. And so what we know from the pathogenesis of this disease is it rises in a single lymph node or a chain of lymph nodes, and it spreads to adjacent nodes. But we talk about constitutional symptoms. So these are the B symptoms. And where B symptoms come from, it comes from a person named Ann Arbor who staged lymphomas from 1 to 4 and then put systemic symptoms into category either A or B. And A means absent or B present. And so when we talk about B symptoms, they're talking about systemic symptoms. And that's what, fever, night sweats and weight loss tend to suggest it's broader than just localized. And so, there's other weird symptoms like, severe itching and fatigue. But there's this odd one, which there's increased sensitivity to the effect of alcohol. So if someone's got this and they drink alcohol, they can sometimes get pain in their in large lymph nodes because of, I'm not sure what reaction, but that seems to be a, associated symptom. And they can also present with fever of unknown origin. So it's just something to consider. But what we know from the histology is that nodular sclerosis and lymphocyte predominant usually present without systemic features. So that can be a sort of a stage 1 and 2. And then if we get ones like mixed cellularity and lymphocyte depletion, they can have those B symptoms like, fever, night sweat, or weight loss, and they can present at a later stage of stage 3 and 4. So that just sort of gives an indication of where the disease is at. And what we know, as we've discussed, is the spread is predictable. So it goes from lymph nodes, eventually it can go to spleen, then it can go to liver, and then it can go to bone marrow and other organs. So we know the progression. But the fortunate thing is, once it's picked up, we manage it really well.
Thank you again, Dr. Travis Brown. This Pathological Life is produced by ClinPath Pathology in South Australia. Episode notes, references and learning objectives, when applicable, can be found at thispathological.life.com.au. And you can contact the hosts on Twitter via @DrTravisBrown or @SteveDavis. Thanks again for listening, and just a reminder, if you haven't done it yet, have a quick search in your podcast app for our second series, This Medical Life. Dr. Travis Brown has rolled up some extra guests, some extra topics, and we continue the story there, and we'd love to have you along.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.